Hospital and is a gold medalist in DNB. I think please start vaccination and in Glomerulonephritis disease. Manish.
Thank you, Dr. Hegde, for kind words. It's always been homecoming when you come to the UGI, and the icing on cake is to when you meet Dr. Dabhi person. So I thank Dr. Sushil Sir, sir, Hardeep, Abhijit, and Akash for giving me this opportunity. Since yesterday morning, we are listening too much about immunosuppression. We have heard about various antibodies, various immunosuppressive agents, but we haven't discussed the ugly face of immunosuppression. So I'm going to discuss about vaccination in prophylactic and glomerular disease. Basically, I've taken liberty to include prophylactics also because I thought that probably vaccination alone is not sufficient enough. And when I searched the literature, there is scanty literature, especially in glomerular disease. So what I've done is I'll be discussing more about vaccination and prophylactics in immunocompromised patients rather than particularly about glomerular disease. We have various protocols, infection timeline, vaccines, prophylactics, and renal transplantation. But unfortunately, we do not have any literature regarding what should be the ideal schedule. And I don't think anyone can follow the schedule, especially in glomerular disease. So what I'll do is I'll start with case presentation, just to give the flavor of this topic. Mr. HD, 24-year-old male patient presented with Hinasarta in July 23, found in nephrotic syndrome, underwent renal biopsy. It was suggestive of minimal nephropathy. He responded nicely to steroid, but he had to started on CNI in view of steroid dependency. Recently, he had to be on increased dose of steroid in view of relapse. 15 days back, he presented with a painful skin disease, which we all know. This was like herpes zoster. Coming to the second case, this transplant patient, 39-year-old female, she underwent transplant in June 24. Her native disease was undetermined. She had a pre-transplant abdominal tuberculosis. There was a 6-month tuberculosis treatment. The donor was her mother, 59 years old. In view of low-risk transplant, she didn't receive any induction. She was on standard maintenance immunosuppression consisting of tacrolimus and steroid. She had stable graft function over a period of 6 months, creatinine improvement in around 1. She was on prophylaxis and she was on ifenazeid for her tuberculosis. She presented to me on 1st December with abdominal pain and persistent vomiting. The abdominal pain was in epigastric area. The physical examination didn't reveal much except mild epigastric tenderness, which was normal. Her primary investigation revealed hyperemia and elevated liver enzymes. The enzymes were in the range of 200. She had normal immune function, normal hemogram, normal urine analysis. And this was the report. She was admitted, started on IV fluid, supportive treatment, and hypertonic saline. Exactly second day, she developed this skin disease. PCR for visit was strongly positive. Within 48 hours, she developed pulmonary liver failure with resistant shock and eyelash. So these two cases show us the ugly face of immunosuppression. One had herpes zoster, second is disseminated varicella infection. Now coming to the subject, though the impact of infection on immunocompromised patients have been known since the decades, but after the COVID pandemic, we understand the vulnerability of our patients of kidney disease, either acute or chronic infection-related morbidity and mortality. With the continuous expansion of immunosuppression armamentarium, the antibody-mediated or the autoimmune renal diseases have better early and sustained disease control, resulting in improved short-term and long-term outcomes. However, sometimes the morbidity and mortality related to immunosuppression are much higher than the disease itself. So basically, in immunocompromised patients, the infection risk is a combination of risk related to disease and the factors related to therapy. So these factors are complex interaction between host and environmental factors. the mode and intensity of immunosuppressive treatment, type of kidney disease, degree of underlying chronic kidney disease, age of patient, extrarenal involvement, and coexisting comorbidities, especially diabetes and pulmonary disease. A substantial proportion of patients exhibit disease or treatment-related lymphopenia, which is associated with increased infection risk. In systemic disease, many times lung involvement is there, which predisposes patients to the recurrent respiratory infection. And most of the patients who have nephrotic syndrome has renal losses of immunoglobulin, which link to the serious infectious complication. They also reduce the vaccine efficacy. Hypogamma-globulinemia, which is an inherent risk of rituximab and B-cell depleting agent, is a known risk factor for recurrent infection. The low baseline immunoglobulin level predicts the risk of secondary immunoglobulin deficiency, which is related to disease or previous therapies. The leukopenia related to cyclophosphamide is inherent risk of infection. When you combine various immunosuppression, this is like innate state of immunosuppression which is generally used in transplant scenario, which decide about the vulnerability of infection. And recently, the term secondary immunodeficiency related to kidney disease has been coined to combine all the risk factors which are associated with immunodeficiency. So, it's a slide, but it shows that when you have secondary immunodeficiency related to chronic kidney disease, it disrupts adaptive immunity, innate immunity, and there is a bacterial overgrowth, infection, higher infection risk, and it also attenuates sterile inflammation. This paper published in 2022, which looked at immunosuppression exposure and risk of infection-related acute care events in patients with glomerular disease. This was prospective observational study. They enrolled almost 2,300 patients from various 71 clinical sites in North America and Europe. These are basically biopsy-proven glomerular diseases, and they modeled immunosuppression exposure on a weekly basis. Patients were on various immunosuppression. The median period of exposure was 3.2 years, and the outcome was infections leading to either ER visit or hospitalization. Now, in this group of patients, at least 15% experienced outcome-defining infection, and when they look at the hazard ratio, steroid alone was associated with 2.65 hazard ratio. So they concluded that corticosteroid with or without concomitant additional immunosuppression significantly increased risk of infection leading to acute care utilization in patients with glomerular disease. The second paper looked at infectious complication in patients with primary glomerulonephritis conference. This paper published from Turkey. They took all the patients with biopsy-proven primary glomerular disease, and they followed over a period of 10 years. They divided the patients into immunosuppressive group and the patients who were continued with conservative treatment. The infection rate was 0.2 per patient year. The total infectious complications were naturally higher in the immunosuppressive group than the conservative group, and the most commonest involved organ was lung. And surprisingly, 15% of their patients had CMV reactivation, which was relatively higher in glomerular patients. And when they looked at the relative risk of infection, age more than 50 years, serum albumin of less than 2.5, and the exposure to cyclophosphamide and cyclosporine were independently associated with increased risk of infection. And they concluded that because of high seropositivity in their patient, it might be a wise approach to use prophylactic antiviral drugs in patients with immunosuppressive treatment. I'll come to that later on. We have discussed about these therapies since yesterday, but just to give you the flavor of this, that most of our renal patients receive some kind of immunosuppression because it is either antibody mediated, complement mediated, T-cell mediated, or sometimes antigen antibody mediated deposition. The most commonly used drug is, we all know, it is rituximab, and it is associated with depletion of B cell. Now, this will lead to adaptive B cell response to vaccination and infection. And half of patients develop hypogamma-globulinemia, which lasts up to 6 months after the completion of therapy, but sometimes this may stay up to 2 years also, which predisposes them to the infection. as well as the reduced responsiveness of the vaccination. The newer anti-CD20 like ocrelizumab, ofatumumab, and obinutuzumab have been now increasingly used in various glomerular diseases, especially in resistant nephrotic syndrome. Belimumab was tried in lupus nephritis, and we all know that in this lupus nephritis trial, belimumab was not associated with increased infection as compared to standard immunosuppression. However, in that series, the PJP infection was slightly higher in belimumab group. Other B-cell depleting agents, daratumumab and bortezomib, they are not really became, but now it has been used in various refractory cases. We all know about the exon of T-cell targeted agents, calcium inhibitors, furin synthesis inhibitors, and B-cell depleting agents. Why I am discussing this? Because these agents are associated with certain set of infections. So, B-cell depleting agent, especially CD20, is associated mainly with encapsulated bacteria and viral reactivation, like Hep B, Hep C, herpes simplex, herpes zoster. They are also been associated with tuberculosis, PJP infection, JC virus infection. And the duration of this stays till 6 months after the last dose of rituximab. Belimumab, as we discussed, has been associated with increasing PJP. The terminal component pathway already Dr. Lobo discussed, but which basically target membrane effect complex, and it has been associated with invasive meningococcal and disseminated gonorrhea infection, and it still patient receives this agent. Calcineurin pathway, tacrolimus and cyclosporin are generally associated with herpes simplex and herpes zoster, and they still use this drugs. MMF and azathioprine have been associated with CMV, EBV. CD52 alemtuzumab, which is a monoclonal T-cell depleting agent, has been associated with reactivation of hepatitis B, and it is the black box warning that whenever you are using this agent, you have to treat with antiviral. I'll come into it later. And the risk stays till 12 months after you give last dose. Polyclonal anti-T-cell ATG has been also associated with various viral reactivation, invasive fungal infection, and parasitic infections. And again, the risk here stays till 6 to 12 months from last dose. Steroid and cyclophosphamide using frequently associated with various viral infection, invasive fungal infection, and parasitic infection. Now, these 6 infections are generally common in immunocompromised patients. These are CMV, VZV, influenza, hepatitis B, pneumocystis, and pneumonitis. For CMV, the increasing risk of infection is there when you use steroid of more than 20 milligram, plus or minus other immunosuppression, and there are certain disease-related risks like SLE, longer disease duration, lymphopenia, age, and late ethnicity. For varicella zoster virus infection, glucocorticoid of more than 20 plus or minus other immunosuppression, or cumulative cyclophosphamide dose, which gives high risk for VZV reactivation. The underlying disease-related risk like SLE, CKD, lymphopenia, females are more common. For hepatitis B, generally rituximab and high-dose glucocorticoid therapy has been associated with reactivation. For pneumocystis, glucocorticoid dose of more than 20 mg for more than 4 weeks, cyclophosphamide rituximab has been associated with increased risk. And as far as disease specific risk is concerned, it is generally more common in ANCA-associated vasculitis, underlying CKD, or underlying lung disease. Before you immunosuppress any patient, ideally you have to go through certain screening investigation to know about the exact risk of getting infection. Ideally, before screening, a thorough history, physical examination, exposure history, travel history, patient surrounding, patient's diet history, up-to-date vaccination history, everything is mandatory before you do this screening test. For hepatitis A, hepatitis antibody is required. For hepatitis B, battery of test, ideally one should do hepatitis B surface antigen, hepatitis B surface antibody, and 4 antibody. Because sometimes if patient is HBsAg negative but 4 antibody is positive, that means patient is infected previously and there are good chances after giving B-cell depleted therapy, patient may have reactivation. Almost 10% patient will have reactivation, and sometimes patient may develop fulminant leukocytosis. So in this set of patients, you need prophylaxis. Hepatitis C antibody is needed, and if antibody is positive, patient should undergo PCR for viral load. HIV generally we depend all the time. For varicella zoster, CMV, IgG is required for PCR test. Strongyloidosis is many times forgotten, but the screening test for strongyloidosis is very easy. The serology of strongyloidosis gives you almost 90% of specificity and sensitivity. And for latent tuberculosis infection, either chest X-ray or IGA is needed. So coming to the vaccination in glomerular disease, in a recent Swiss cohort study, 11.9% of solid organ transplant recipients experienced at least one vaccine preventable infection, which is almost 43 times higher than the general population. Though the magnitude of this infection is probably lower in non-organ transplant immunosuppressed patients, but nonetheless it highlights the importance of vaccination as a prophylactic strategy against infection in this group of patients. The response rates to vaccine are frequently blunted in these patients because of B-cell depleting agents. Sometimes high level immunosuppression is associated with suboptimal seroconversion rate, and ideally the immunosuppression should be completed before starting immunosuppressive therapy, but generally it doesn't happen because of the urgency of starting treatment, and sometimes the vaccine protocol is complicated, so you may not be able to complete the vaccination before starting immunosuppression. This slide just shows why CKD patient has less immune response because of various problems of monocyte, macrophage and dendritic cells dysfunction. There is reduced number as well as impaired endocytosis. There is failed maturation. There is a reduced number of toll-like receptor and defective function. So there will be less antibody production. At the same time, the long-life plasma cells, which are generally required for long-term protection, are not developed at that level in CKD patients. So that is why probably the protection of antibody will not last longer as it occur in general patients. These are the list of vaccines for any patient who are initiating on immunosuppression. I will take one by one. So this is a standard protocol we generally follow in our CKD patients: hepatitis B, influenza, pneumococcal and herpes zoster. This protocol we all know and we follow it in our CKD patients. Hepatitis, the patients who are seronegative for hepatitis A or who are negative for hepatitis B ideally should receive full vaccination against this virus. And ideally the first 1 or 2 doses should be given preferably before starting immunosuppression. Hepatitis A vaccination consists of 2 doses, 1 ml intramuscularly, and second dose is given 6 to 12 months after the first dose. Hepatitis B vaccination, 4 doses series depending on patient's underlying renal insufficiency. Generally, patient requires double dose plus extra doses. There are combined hepatitis A and B vaccination available. If patient requires both vaccination, one can give Twinrix 1 ml 3 doses, 0, 1 to 6 months. And for accelerated response, 0, 7, 21, 30 days, 12 months. This paper recently published, this looked at efficacy and safety of accelerated versus standard hepatitis B vaccination in advanced CKD patients. Here in accelerated regime, they give hepatitis B vaccine at 0, 1, 4 and 8 weeks, and standard regime 0, 4, 8 and 24 weeks, which we generally give. At 12 weeks, the response rate in accelerated regime was high as compared to the standard regime. Though at the end of 28 and 52 weeks, the seroconversion rate was same. But if you want rapid seroconversion, though I'm not sure whether we can extrapolate this data into our immunosuppressed patients, but when you want to give immunosuppression and then you are in hurry to give rapid seroconversion, probably we can use this protocol. Influenza vaccine patients likely to get immunosuppression must receive annual inactivated influenza vaccine. Live attenuated influenza is contraindicated in immunocompromised patients. Inactivated influenza vaccine is available in India in various treatments, but 0.5 ml intramuscular before winter and annual vaccination is must for immunocompromised patients. Live attenuated influenza vaccine intranasal is also available, but it is contraindicated after starting immunosuppression. There are the various methods to enhance the efficacy of hepatitis B virus in seasonal influenza vaccine virus, because the response of influenza vaccine virus in CKD patients is sometimes as low as 30%. So, these are the various means by which you can increase the efficacy of vaccination: intradermal administration, high dose, extra dose, combined with novel vaccine epitopes, and sometimes by using adjunct, one can increase the efficacy of this viral response, vaccine response. Pneumococcal vaccination is must in immunocompromised patients because they are quite common in glomerular disease patients, especially when patient is receiving B-cell targeted therapy. The Streptococcus pneumoniae have several serotypes, and 23 common serotypes, which is generally included in our vaccination, accounts for more than 80% of disease burden. If the PCV20, which is 20-valent conjugated pneumococcal vaccine, is available, the single dose of PCV20 is sufficient. But when PCV20 is not available, as per standard of care, PCV13 followed by PPSV22 after 8 weeks is the standard of care. Herpes simplex virus and varicella zoster virus reactivation is a frequent complication. It generally occurs with T-cell mediated immunosuppression. So, vis-a-vis status is must for patient. If patient is seronegative, then primary vis-a-vis infection can be considered, especially if patient is not immunocompromised. But once patient has started immunosuppression, vis-a-vis primary vaccination is not it's contraindicated. For vis-a-vis seropositive patient after 50 years of age, we can give recombinant zoster vaccine, which is Shingrix. And for less than 50 years after combined PCV pairing, one can give Shingrix for less than 50 years for seropositive patient. A varicella vaccine should be given 6 weeks before initiating immunosuppression, and as we discussed, it is contraindicated after starting immunosuppression. The live attenuated varicella vaccine is available in various treatments. With the 2 doses series, 0.5 ml intramuscular subcutaneous. The dose should be separated by 4 to 8 weeks. So if you can finish this vaccination before immunosuppression, that is before starting immunosuppression, that is well and good. The recombinant adjuvanted zoster vaccine, that is Shingrix, 2 doses, second dose, 2 to 6 months after first dose. Live attenuated zoster vaccine is also available, but it is not used in immunocompromised patients. In immunocompromised patients, when an exposure to varicella or herpes zoster occurs, prophylaxis with antiviral therapy or immunoglobulin reduces the risk of developing varicella. So when patient is having exposure, acyclovir should be started as early as acyclovir or valacyclovir should be started as early as possible. Meningococcal infection in complement inhibitors have been discussed, but just to complete the list, the complement inhibitors eculizumab and revalizumab inhibit the final common pathway of complement, in which all pathway converge to form the membrane-attack complex that lyses microbial cell membrane. Now, this is needed for encapsulated bacteria, especially for meningococcus and gonococci. A recent pharmacovigilance study identified a relative risk of 496.5 for meningococcal sepsis, 203.8 for meningococcal infection, 542.7 for meningococcemia, and 210.6 for meningococcal meningitis when compared to control treated with rituximab. So we can tell that meningococcal infection is highly likely when you use a complement inhibitor, and that is why the product monograph recommends vaccination of all patients with quadrivalent meningococcal vaccine containing serotypes of A, C, Y, and W135, as well as 2 doses of meningococcal B vaccine. A meningococcal vaccine, the quadrivalent Menectra, is available in India, 0.5 ml intramuscular single dose between 2 to 55 years of age. And meningococcal vaccine should be administered at least 2 weeks before the first dose of eculizumab. And during those period, ideally patients should be on prophylaxis with penicillin B. In Europe and UK, they have fill in pocket kind of protocol in which they give penicillin B, but they give ciprofloxacin to the patient. So when they have symptoms, they should start ciprofloxacin as the symptoms first, because once they develop meningococcemia, it is very life-threatening kind of condition. Additional vaccine consideration, COVID-19 vaccination, we all have enough learned about COVID-19 vaccination, but it should be as per local protocol and should be up to date even if patient is on immunosuppression, because there is some efficacy when you give COVID-19 vaccine in immunocompromised patient. RSV vaccination has been approved recently in US in 23 and in Europe and UK has been approved in last September. There is one adjuvanted and one non-adjuvanted vaccine has been available. They have been approved for adults more than 60 years to prevent hospitalization. In UK, the age limit is 75. In US, it is 60 years. If MMR vaccination status is unknown and patient is seronegative, ideally patient should be vaccinated before starting immunosuppression if it is possible. As far as HPV vaccination is concerned, 3 doses for patients less than 26 years of age, and for more than 26 years of patient after shared decision making, one can give HPV vaccination. For monkeypox vaccination, 2 doses of non-replicating smallpox vaccine for at-risk patients, and this can be given in immunocompromised patients because virus is non-replicating. Yellow fever vaccination is absolutely contraindicated when patient is on immunosuppression, but when patient is traveling to endemic area, one should consider this vaccination when patient is not on therapy. Now something about prophylaxis for PJP infection. It causes severe interstitial pneumonia with marked hypoxia, and it can readily be prevented with a variety of prophylactic regime. As per Cochrane analysis, PJP prophylaxis leads to an 85% reduction in the incidence of infection and 87% reduction in the mortality in non-HIV patients. But what is the ideal time, or what is the time when you should give PJP prophylaxis in immunocompromised patients or the glomerular disease patient? The recent guideline says that when patient is on 20 milligram of steroid for at least for 4 weeks, either alone or in combination with other immunosuppression, or patient has received rituximab with another agent, patient should be on PJP prophylaxis. As far as prophylaxis is concerned, sulfamethoxazole and trimethoprim single dose every day or double strength 3 times a week can be utilized. If patient is sensitive to sulfa, dapsone, atovaquone or IV pentamidine monthly can be used. For CMV prophylaxis, it is relatively rare complication after B-cell depleting therapy, but it can be frequent complication, especially when you use T-cell depleting agent. There is not enough data in the non-transplant setting, and though the patient's serostatus should be determined, the primary prophylaxis at this time is not recommended outside high-risk transplant patients, but one can use it from patient to patient basis. When your patient is having nephrotic syndrome, what is the ideal time of giving vaccine? So this is a practical scheme. If patient is in remission, there is no therapy, it is a time to complete vaccination if possible. So one can use inactivated vaccine, recombinant vaccine, toxoid vaccine, COVID vaccine, as well as live attenuated vaccine also. If patient is on therapy, and this therapy is consisting of steroid, MMF or CNI, patient should receive inactivated, recombinant, toxoid and SARS-CoV-2. And one should not give live attenuated vaccine at this stage. If patient is received or patient is on monoclonal anti-CD20 antibodies, one should wait at least for 6 months after last infusion. So that is the practical approach of how to give vaccine in nephrotic syndrome. This slide shows everything. What is the risk factor? What should be the preventive option? I will not go into the detail of this. We already discussed this. And lastly, the KDIGO 2021 clinical practice guideline. What should be the recommendation, the use of vaccine and prophylaxis in patients with glomerular disease? Use pneumococcal vaccine in patients with glomerular disease and nephrotic syndrome as well as with CKD. Patient and household contacts should receive the influenza vaccine. So not only the patient, household contacts should also receive. And patients should receive herpes zoster vaccination, that is syphilis. Screen for tuberculosis, hepatitis B virus, hepatitis C virus, HIV and syphilis in clinically appropriate patients. Strongyloidosis superinfection should be considered in patients receiving immunosuppression who once resided in endemic tropical environment and who have eosinophilia and serum immunoglobulin level are high. Prophylactic ceftriaxone should be considered in patients receiving high-dose prednisone or other immunosuppressive agents. So key takeaways from this presentation is thorough pre-immunosuppression screening is crucial for the risk assessment. Individualized antimicrobial prophylaxis based on patient risk factor. Maximize vaccine-induced immunity before initiating immunosuppression. And maintain continuous risk assessment and patient education throughout the therapy because the patient may develop infection at any point of time. Thank you.
Thank you, Dr. Manish, for the detailed review. I have one question. For rabies post-exposure prophylaxis, how you deal with it in case patient? So if somebody is on immunosuppression, will you give some immunoglobulin along with the vaccine?
It depends on patient's exposure. But as far as immunocompromised patient is concerned, there is no contraindication of rabies vaccination. So I would vaccinate as we vaccinate our known immunocompromised patients.
Thanks a lot, sir. Excellent session.